But you can get
Hello. All right, well, this is going to be pretty informal, and maybe we can, Mark, thank you for putting this together. This is nice. Gosh, this is real nice.
You're welcome, sir. Tressa printed those.
I'm sorry, she printed those? Yes, those are nice. I'll take some anyway, and I'll give one to Amrita, but thanks for coming. All my friends. This is a talk that I gave at the end of April with Mark's expert help on the slides. I obviously couldn't have given this talk at all without Mark, but I gave it to the American Association of Oral Medicine. Is that right, Chico? Yeah. It's a group that Chico got me invited to give this talk. American Academy of Oral Medicine. And they wanted me to give an introductory talk for an annual meeting that focused on diseases of aging with respect to oral medicine. So they gave me a title, and that was this title, Changes in Disease Patterns in the Elderly. I wasn't really sure how to approach this title. I didn't ask them to change it, so I thought about what I knew about the changing demography of the aging population, which we all know what that is, and also the common disorders in this expanding aging population. And then I drew on what I knew in my area of therapeutics that are either currently available or in development for common metabolic disorders. And I came up with a theme that tried to address this title. And that's what I'll try to develop for you in the next little while. What do I do to advance this?
Have to hit.
Yeah, this is something I don't have to give for you. So this is the basic fact about the demography. We all know this. The demography of aging populations. Oh, let me just say that as I developed this talk, I tried to make it do double duty. And because anything that I wanted to learn, I wanted to share with you, and since my interests, research-wise, certainly interact with, cross-react with those of you in this room, I felt that maybe I'd learn something that was useful to all of us. And in putting this together, I came up with perhaps only the vaguest kinds of interactions, but ones that I think we would be poised to work on because other people would have gone on to maybe other aspects of what I'm going to mention, but not the kinds of age-related questions that perhaps we could address in this room. And so that's really why I'm giving this talk now, is because of course, I preempted a lot of the punchline in individual conversations with you all. I think a lot of you have heard some of these new developments that have occurred in bone and metabolic disease, but I wanted to put them in context of this talk. So that's why I'm giving this talk today. So in terms of the demography of aging populations afflicted with age-associated diseases and geriatric syndromes, necessitates that healthcare practitioners in the 21st century will treat increasing numbers of older people with multiple chronic conditions. That's probably what you already know. And this is just one of a number of projections of the U.S. population that is available through standard textbook, showing that from 1900 through 2000 and then projected to 2050, you see increases in the populations in the United States greater than 65 years old or greater than 85 years old, so that you see something like a 25-fold increase in greater than 65-year-olds, and 85-year-olds 200-fold increase. Really remarkable. Between 2000 and projected to 2050, you see about a 2-fold increase in the percent of the total population at either age, 65 or 85. So it's going to double in the next 40 years. And that
are there going to be a definition for old or for?
Well, there already are pseudo definitions for old. The age cutoff, I shudder to think, is sort of 65. I mean, you're dealing with a chronologically healthy older population beginning at age 65 in this country anyway. And then when you talk about the quote oldest old population chronologically, you're generally talking about 85 years or beyond. And that's a population that is assuming great interest in the public health sector because it didn't exist back in the 1900s, but does now in a very significant part of the population. The same doubling of the older population that exists for the United States population exists for developed and developing countries around the world, even though the numbers may be less in some of the other populations. But here's a slide that's worldwide populations projected between 2000 and 2030, greater than or equal to 65. There's Europe and North America, about a doubling, but then you get to Latin America, Asia, the Near East, North Africa. I don't know about that last one, but you can see that throughout the world you're seeing increasing numbers of aged populations in absolute numbers, although they're I'm sorry, in terms of percentage numbers of the population. So that's a tribute to the public health advances, I think, worldwide. So what kinds of disorders are we dealing with in this population, at least in the United States? Here are some common ones. I've listed this as startling statistics because it's really quite amazing to see how prevalent these conditions are in the older population in the United States. Osteoporosis, 13% of those over 50 years. And I want to emphasize how surprising the fraction or the frequency of men as opposed to women is. 30% of osteoporotics are men at over 50. And if you look at low bone mass or osteopenia defined by bone mineral density measurements by the World Health Association, World Health Organization, and osteoporosis associations, you have 42% of the population over 50 has some degree of bone loss, and 50% of that is men, which is really surprising. Diabetes, we've known this for many years from the nutritional health and health and nutritional education studies over the years, so-called NHANES studies, that 25% of the population over 60 have diabetes, and half of those don't even know they have. If you look at pre-diabetic conditions, if you will, impaired fasting glucose or impaired glucose tolerance, 14%, 20%. If you add up the people with impaired glucose tolerance and diabetes in the U.S. population over 60, half of them, 45. Frailty is a condition that sort of like the U.S. Supreme Court enunciated many years ago as to pornography. It's something that you may not be able to define, but you know it when you see it. And it's becoming a well-defined entity, largely because it is so prevalent. And it's a little hard to get prevalence figures, but it's estimated that up to a quarter of people over 65 and up to almost half over 85. And I'll talk a little bit about definitions of frailty in a few minutes. Dementia. These are results. These are figures from the Health and Retirement survey from a few years ago. This is a little more conservative than previous estimates from the early 1980s that estimated that up to half of all community dwelling elders had some degree of cognitive decline, not necessarily dementia. But here you see, if you define if you look at dementia per se, up to a third or so of people over 90 have some degree of dementia. Pre-dementia type syndrome called cognitive impairment without dementia per se is up to 40% of the oldest older. And then vitamin D inadequacy, which is a relatively newly appreciated entity with multifactorial associations with disease, which I'll also talk briefly about, is found anywhere up to 100% of community dwelling elderly. And I will say that now that I'm in practice, I utilize that rightly or wrongly to actually diagnose vitamin D insufficiency, and you'll see a little bit of the consequences of that. So, realizing that there's an increasing number of older people with these very, very common problems, and that people like me are going to, as long as I survive, are going to have to take care of them, this is sort of the theme that I've tried to develop for this talk that refers back to this title. As the health needs of an expanding older population are increasingly recognized as a heightened societal priority, emergent translational research, I sound like I'm writing a grant, but the emergent translational research identifying new therapeutic targets will redefine patterns of diseases. And then this is important, I think, for our purposes today. And even the clustering of multiple diseases in the elderly by innovations in effective treatment. So putting that in English, these diseases are going to be redefined by what treatments we have that are going to become available for them. And the kinds of disorders that I focused on in this talk that I'd like to discuss at least briefly today. Maybe I'll skip this one. But I was giving this to an oral medicine group, and so I definitely had to focus on this. Are these disorders? And the first one I'll talk about is one I know a little bit more about, and that's osteoporosis. And in terms of the therapeutic agents that are available to treat osteoporosis, they are segregated into two types of agents that address defects in bone mass based on abnormalities in the normal bone remodeling sequence. And this is one of any number of classic figures illustrating how the normal sequence of bone turnover that repairs micro fractures, that keeps bones strong, and that allows for homeostasis of calcium and mineral metabolism in circulation. Initially, there's some kind of a stress or even a micro crack or something that develops in the bone matrix. And there's two cell types that, of course, are always clearly involved in bone remodeling: the osteoclast, which resorbs bone, and the osteoblast, which forms bone. There's a third cell type that is not shown in this slide, but is now being appreciated as having a very, very significant role in bone remodeling, and that's the osteocyte, which seems to be what osteoblasts after residing in the bone for a long time, become. And so osteocytes somehow sense the original insult and then signals from the osteocyte signal the osteoclast, a multinucleated giant cell, to come in and through its ruffled border surface resorb bone. This bone resorption then calls into play osteoblasts, which come in to line the bone remodeling unit and then put down matrix or osteoid and rebuild that section of bone. And the whole process takes what, along 3 to 6 months, actually, I think. So
you were shown like osteoblast precursors come and settle on bone, and then they become osteoblast or osteoblast. It is just an idea.
In this theoretical model, osteoblasts are the ones that are doing the bone formation. Now, what comes in is possibly precursor cells or stromal cells that then differentiate to osteoblasts. This is a very simplified scheme. And there are two kinds of osteoporosis that we should, I believe, try to distinguish one from another. The first is postmenopausal osteoporosis. In the absence of estrogen in the postmenopausal period, there is an increase in bone resorption that cannot be compensated by a coupled increase in bone formation. Normally, in normal bone homeostasis, these processes are very closely coupled. When bone resorption increases, bone formation increases according to this scheme. In a postmenopausal female, in the absence of estrogen, through growth factors or any other number of reasons, osteoclasts are activated and cannot be matched in their activity by osteoblastic bone formation. On the other hand, after the menopause, both women and their male counterparts have a gradual decline in bone loss that, for want of a better word, may be called osteoporosis of aging or bone loss of aging, that is thought to be more related to osteoblast, defective osteoblastic bone resorption as the primary event. So the therapeutic agents are those that inhibit the osteoclast or that activate the osteoclast.
You have
I spent too much time on this slide. So these are the agents that can be grouped under anti-resorptives or anabolic agents. And I put the ones that are currently being used in blue and the ones that are emerging on the basis of even preclinical evidence in red. So the one that's used primarily and that's been used for the past 15 years or so is a class of agents called bisphosphonates, which I'll show briefly on the next slide. I only want to touch on the blue agents and then go on to the red ones. SERMs, selective estrogen response modulators or estrogen receptor modulators. These are agents that act like estrogen on bone to protect against that increased resorption, but unlike estrogen, do not have agonist effects on reproductive tissues, but rather antagonist effects on reproductive tissues. So you do not develop the increased risk of breast cancer or the increased risk of uterine cancer that has so altered our treatment of postmenopausal women with estrogen per se. And in fact, these are treatments for breast cancer. So there's one agent, raloxifene, that's widely used now, but there are at least 3 in development that have higher potency than raloxifene, and we may see come into play very shortly. Parathyroid hormone, in terms of an anabolic agent, absolutely fascinating literature that goes back probably 60 years or so. But it's been long known that parathyroid hormone over-secreted in high amounts without pulsatile change, as in primary hyperparathyroidism from parathyroid adenomas, primarily causes bone resorption and bone loss. in the disease of hyperparathyroidism. But it was known for many years, but not used as a rationale for a therapeutic target for about 40 years or so, that if you pulsatile if you increase PTH in a pulsatile fashion, perhaps once a day, it has an anabolic action. And that has now been used therapeutically by so that PTH in the form of something called teriparatide or Forteo is now used as the only FDA-approved anabolic agent in the United States for osteoporosis. Very effective. Has to be given subcutaneously. It has some side effects, GI intolerance side effects, and can't be used more than 2 years because in animal models, 2 years of therapy at many times the dose given in humans, it can produce osteosarcoma. And it does have some hypercalcemia tendency, as you might guess. Strontium is a cation that's used in a ranolate salt in Europe. It's approved in Europe. It's not approved in the United States. It substitutes for calcium in the bone matrix, and because it has a higher atomic weight than calcium, it increases bone density. But also, it's very difficult to measure bone mineral density in people who are treated with strontium because it gives false readings on these bone densitometers, so we have to be careful with that. But it has modest but clinically, statistically significant effects to decrease fracture rate. I've listed it here as an anabolic agent because it sort of makes the bone stronger, but it's also been shown to inhibit osteoclast function for reasons that are not clear to me anyway. So let's talk about some of the other agents on this slide. First, bisphosphonates. This is an agent that has revolutionized therapy for osteoporosis now that it's been available. These agents have been available over the past 15 years. They're available in oral forms, and more recently have become available in intravenous forms. And the most potent nitrogen-containing bisphosphonates, something called alendronate or Fosamax, or ibandronate, Boniva, that you see Sally Field advertising for, that can be given orally or intravenously, or zoledronic acid, which is the most potent, which is given once a year intravenously. Over the past couple of years, that's been licensed and has been used frequently. But the way these agents act is what's so interesting. They act as inhibitors in the cholesterol biosynthetic pathway to inhibit farnesyl pyrophosphate synthase, which which is responsible for producing these prenylated long fatty acid chains. Farnesyl pyrophosphate, geranyl diphosphate, I think it is, which then go to prenylate small molecular weight G proteins to allow them to intercalate onto the ruffled border membrane of osteoclasts, to allow osteoclast differentiation, proper resorptive function of osteoclasts. So these are agents that directly inhibit the osteoclast on that basis. And very widely used and very effective in reducing fractures of the hip, fractures of the spine. But there are associated side effects that the group that I spoke to, as Chico would know, has great doubts about the use of this because they're very rarely associated with defects in bone in the oral cavity called osteonecrosis of the jaw. The dentist population has brought this most to light, and yet the frequency in people who are using bisphosphonates seems to be very, very low in general. It's characterized by exposed bone in the maxillofacial region that does not resolve within 8 weeks. It's associated with oral bisphosphonate therapy for osteoporosis between 1 in 10,000 and even less than 1 in 100,000. So in most circles it's believed to be very rare. So the question comes up, what about these new very potent IV forms of bisphosphonate. The best I can do there is to cite the data on the zoledronic acid or reclassed, 2 articles published in the New England Journal, 5,000 patients in the placebo group, 5,000 patients in the reclassed group. 1 patient in each of those 2 groups had osteonecrosis of the jaw. It is true that the risk increases in cancer patients treated with high dose of IV bisphosphonate. In other words, IV bisphosphonates are also used for metastatic bone disease in cancer patients. And in those patients, the frequency is clearly higher, up to 1 in 10. But those are much higher doses. So we have to be aware of this as a side effect. And the patients come in and they ask us about it because they've been warned by their dentist that maybe they should not get this agent. Predisposing factors: longer duration and potency of IV bisphosphonate, dental periodontal disease, dental surgery, oral trauma, poor dental hygiene, cancer or its treatment, glucocorticoid treatment, alcohol, tobacco. Well, there's a new agent that should be up for approval by the FDA, an anti-resorptive agent that is based, that will provide therapy on a totally different physiologic rationale that was developed by the basic scientists over the past 15 years. And this is, on the left, is sort of the basic physiology that 10 years ago wasn't even appreciated. Namely, that there's a kind of coupling between osteoblasts and osteoblast progenitors with osteoclasts and their progenitors that is absolutely fascinating. A normal physiologic regulation by which the osteoblasts control development and function of osteoclasts. Osteoblasts, or stromal progenitors of osteoblasts, produce a secreted protein called receptor activator of nuclear factor kappa B ligand. It's a ligand for a receptor called RANK, which is one of the TNF family of receptors that exists on osteoclast precursors. And when this secreted protein binds to this RANK receptor, it entrains signaling that allows for osteoclast maturation and function. And what's fascinating is that the osteoblast, in its wisdom, produces simultaneously a dummy receptor-like protein for the RANK ligand, and that's called osteoprotegrin. So that this can bind up the RANK ligand and prevent development of mature osteoclasts. So it's a fine-tuning, a regulation that is begun by one or both of these proteins produced by the osteoblast. Well, you can imagine how the pharmaceutical companies have seen this as a potential for control of too much osteoclastic bone resorption. If you were to overproduce something that looked like osteoprotegrin, you could bind up all the RANK ligand and prevent the development of too many osteoclasts in, say, postmenopausal osteoporosis. And so that's shown here on the right, that you produce more inactive complexes and there's no osteoclast maturation. So Amgen has developed an antibody to a RANK ligand that serves as an osteoprotegrin a mimetic. And that's called Denosumab. And a phase 3 trial of Denosumab was reported at the American Society for Bone and Mineral meetings last year, and won't be published probably until the drug, just before the drug comes out in the fall. But you'll see a huge article in the New England Journal when just before this comes out. So that's how the medical literature proceeds in 2009. But this is really impressive data. Almost 8,000 postmenopausal women with osteoporosis randomized to placebo versus denosumab, which is given subcutaneously only once every 6 months. So that's going to be very popular, as opposed to having to give IV infusions once a year. Those IV infusions can sometimes have their own side effects, but this looks very promising. But huge reductions in vertebral fractures, non-vertebral fractures, and hip fractures with denosumab, comparable to or even greater than the effects of bisphosphonates. Very significant, similarly, very significant increases in bone mineral density of the lumbar spine, 9%, that's a huge amount. Total hip, 6%, and forearm. And there are no differences in adverse events or so-called serious adverse events between placebo and denosumab, including no osteonecrosis of the jaw, so they'll be advertising that quite a bit. You're going to see a lot of this on television. Looking at another agent, which is quite interesting, there's been a lot of interest in trying to inhibit the osteoclast's function very locally in the resorptive pit, if you will. There's an enzyme that is secreted by the osteoclast called Cathepsin K, and this is a proteolytic enzyme which in the presence of an acidic environment, which is also produced by carbonic anhydrase subtype 2 in the osteoclast. In the acidic environment of this resorption pit, Cathepsin K can have optimal function to resorb bone matrix protein, particularly collagen type 1. So there are a number of agents that have been developed to inhibit Cathepsin K. Only one of them is still in clinical trials because there's a certain non-specificity of a number of these agents that resulted in a skin rash that was pretty nasty. So there's only one agent now that seems to be very specific for this agent, for this process to inhibit bone resorption. It's called Odanacatib. And this was also reported at the bone meetings last year. It hasn't been published yet. Randomized controlled trial of daily oral Odanacatib in postmenopausal women with low bone mass. 2 years of treatment was well tolerated and increased lumbar spine and total hip bone mineral density by very respectable amounts. We may hear more about this agent. I think we will. It will be available. So why are we interested in more resorptive agents when bisphosphonates are available? Well, I mentioned bisphosphonates have some side effects, either becoming more widely appreciated or just or actually are more prevalent perhaps than we think. There are also some hints that the bisphosphonates they seek bone and they stay there forever. They never go away. They're there forever. And there's some hint that there's a peculiar kind of subtrochanteric or mid-femoral shaft fracture that may occur in some of these patients now that we've seen them on treatment for 10 years or more. So there's a little bit of hesitation about how long to keep people on bisphosphonates, especially when the question might come up is, can you combine agents with anti-resorptives with anabolic agents? It turns out that bisphosphonates aren't so good when you combine them with PTH. The effect is not additive. In fact, it's subtractive. But because Cathepsin is a local agent, it's being thought of as possibly not. I'm sorry. The other reason bisphosphonates may be questioned perhaps is because of the coupling between resorption and formation. When you lower resorption with a bisphosphonate, there's a coupled reduction in formation. Whereas that may not occur with these other agents like Denosumab or Cathepsin K. And also there's some suggestion that maybe with Denosumab we may be able to see combination with anabolic agents so that we can't see with the bisphosphonates. Also, they don't stay in bone forever, so there's a more rapid turn on and more rapid turn off of these agents. Well, what about the anabolic agents, which are really part of what I want to emphasize during this talk? One thing I'll mention first, but then we'll deal with it further, is that one of the major developments over the past 20, 30 years in bone cell metabolism has been the elucidation of the calcium responsive receptor that is located on the parathyroid cell and other metabolic and many other cells in the body. And calcium in the parathyroid gland, calcium ions bind to this GPCR calcium sensing receptor and regulate the secretion of PTH. When calcium binds, it decreases PTH secretion. And that has been utilized for drug development in the form of calcium mimetics for treatment of hyperparathyroidism that have excess parathyroid hormone being produced. These calcium mimetics can then bind and in an antagonistic fashion, excuse me, calcium mimetics. In an agonistic fashion to turn off PTH secretion. So that's been used for hyperparathyroidism. In the osteoporosis literature, there's been, since PTH is a useful anabolic agent but has to be given in a pulsatile fashion, there's been the development of oral agents that act as calcium receptor antagonists. And they will, in a pulsatile fashion, at least theoretically, increase PTH secretion. These are so-called calcilytics. There is one that's in development, noracalorate, I think it's called, and in animal studies seem to be very promising, but I think the only clinical trial that I know of has been stopped because it didn't seem to have very much effect in humans. But I think we'll see more of this, and it's absolutely fascinating development in the area of calcium metabolism, to be sure. All attributed to one fellow who was who really spent his whole career knowing and pursuing and proving the existence of the calcium sensing receptors. His name is Ed Brown at the Peter Brent Brigham in Boston. Well, now let's get to some other possible agonist mimetics, if you will, that could treat osteoporosis. And I think in this room you've discussed more than I understand about the Wnt signaling pathway. The Wnt's are a number of cysteine-rich proteins that are important in the development of multiple tissues, including bone. And this scheme has been developed in the area of bone over the past 20 years or so, whereby the Wnt signaling pathway is clearly important for the development of osteoblasts and maintenance of osteoblastic function. In the absence, this is the signaling pathway in the presence of the Wnt protein agonist, and this is in the absence of any agonist. The primary mediator of effects of the Wnt signaling pathway, of the canonical Wnt signaling pathway, is so-called beta-catenin. And the major players of the receptor and ligand complex are the receptor, which is a G protein coupled receptor, frizzle, and not only the Wnt protein, but a co-receptor protein that I want to focus on during part of this talk, called lipoprotein receptor-related protein, either 5 or 6. There are a number of isoforms. The Wnt signal can only occur when the LRP protein is part of a triad between the ligand and its receptor frizzle and this co-receptor LRP. In the absence, so let me go back, in the absence of Wnt binding and co-binding with this LRP, this beta-catenin is phosphorylated by a GEC3 kinase, and its phosphorylation allows it to undergo proteasomal degradation. So it never gets to the nucleus as a transcription factor, which is intended to do as a signaling intermediate. But in the presence of this triad, this kinase function is inhibited. The beta-catenin is no longer phosphorylated. It's free to enter the nucleus and function as a to alter transcription of so-called TCF-related genes. I want to point out these two proteins over here that function as inhibitors of this pathway. One is called sclerostin, which is a product of the gene called SOST, and the other is a series of proteins called the Dickoff proteins. And these proteins bind to and inactivate the LRP 5 or 6. In the case of the Dickoff, it actually hastens its degradation. But in the in the case of sclerostin, it merely makes the LRP unavailable for binding of the Wnt agonist and the fristle receptor. So, of course, we can conceive of pharmaceutical antagonists of sclerostin and Dickoff proteins, such that there's a monoclonal antibody that's been developed to sclerostin by Amgen, which is in clinical trials. And as I recall, at day 65, after one dose of the antibody, which I think is subcutaneously administered, there's an increase in bone density, I think, at the spine of about 6%. I mean, it's really major after one dose. The Dickoff antagonists have been developed only in animals to date, but it also looks promising. So I think this is a very important series of compounds that we'll see coming down the line. But now I want to go into the areas that I think you reviewed some of in the journal club aspect of your calcium club a little bit lately, and that's the role of this LRP 5 or 6. There was a recent editorial written about LRP 5 and 6 that lamented almost, have we been, even though this sequence has been known for what has been incrementally understood over the past 20 years, people are now understanding a totally different function of LRP apart from this scheme, so that a recent editorial has asked, have we been studying the right molecule all these years, but for the wrong reasons? And it turns out, to make a long story short, and this is the name that I want to emphasize as one of our distant colleagues, this guy Gerard Carcenti, who is quite an innovative investigator, and has come out with a number of not only innovative but sort of groundbreaking discoveries in the area of bone cell metabolism and how it's related to intermediary metabolism, which I'll get into in a moment. But this is one of his papers, with the first author being Yadav. Turns out that recent evidence indicates that LRP5 regulates bone formation not by the Wnt signaling pathway in bone. I don't know if that's exclusive. I don't know that this is an exclusive rejection of the Wnt pathway, but certainly there's another pathway that is previously unknown, and it's a gut-to-bone endocrine axis mediated by serotonin produced in the duodenum. Totally unexpected, totally out of left field. What turns out is that the enterochromaffin cells of the duodenum have significant capability through the rate-limiting enzyme tyrosine hydroxylase to produce serotonin, which has direct inhibitory effects on osteoblast proliferation and differentiation. And LRP5 acts in a systemic way to inhibit this enzyme. Very profound new development that certainly, I will indicate in a second, has some drug development potential.
So the
Agonistic or anabolic possible pathway that's in drug development, or that is as we speak being considered for drug development, is this leptin pathway. Leptin, as you know, is a pluripotential molecule from fat cells, an adipokine, that has profound effects on regulation of weight and appetite control. But in a series of groundbreaking papers by Carcenti from about 2000 to 2003 or so, has been shown to have equally profound effects on bone mass. And the way he reasoned this originally was that clinically, obese people seem to be protected from fracture, maybe from bone loss. Of course, obese people have cushions when they fall and don't break their hips because they have more adiposity. But also it turns out that animal models that either don't have leptin or don't have the leptin receptor and are obese, either the OB-OB or DB-DB mouse, are not only obese but are characterized by high bone mass. So through a series of elegant and very complex studies, there are multiple indirect effects of leptin that have been discovered by Carcenti that work through indirectly through action of the leptin molecule on the ventromedial hypothalamus, which then signals the sympathetic nervous system to activate beta-2 receptors in the osteoblast, largely to inhibit osteoblastic, I'll say proliferation, differentiation, development, and function. I believe all of those functions are inhibited, but certainly the end effect is a decrease in bone formation. Of course, the beta-2 receptor is near and dear to my heart, and I've known that beta receptors exist on osteoblasts for many years, but I don't think we knew what they were doing, and this tells us what they were doing. Turns out that there are multiple effects of leptin through this pathway, through the beta receptor, and through mechanisms other than the beta receptor on osteoclasts, on osteoblasts, to increase the function or decrease the function of all of them. It's very complex, but the predominant effect is to decrease bone formation. So there's another question. If you're a clinician, you say, wait a minute, a lot of people are on beta blockers. Is there any information available? Well, this is what you can derive from the existing literature. The negative actions that are newly discovered now for serotonin and this leptin beta-adrenergic receptor pathway on bone, what can we take away as possible drug development clues from this literature? Ovariectomized mice lacking serotonin or beta-adrenergic receptors fail to develop osteoporosis. So this is a standard animal model for postmenopausal osteoporosis. You gonadectomize or ovariectomize animals, they lose bone mass. But if you take away their serotonin, which has a negative action on bone formation, if you take away their beta receptors through knockouts, which have a predominant negative effect on bone formation, they don't lose bone. So this implies that these are very major players in postmenopausal osteoporosis. And then, with regard to, I think what Ben's question was, patients taking selective serotonin reuptake inhibitors for depression can have reduced bone mass. There is an abundance of observational studies. So we're going to have to, not only are we going to have to develop new drugs, but some of those new drugs will have to treat possible bone loss that's in this huge population of patients who are being treated with SSRIs for depression. And finally, the use of beta blockers may reduce the risk of bone fracture by increasing bone density in a number of epidemiologic studies. So this brings up the possibility of some kind of beta blockade or some kind of serotoninergic antagonism for treatment of bone loss during aging. So you've got these agents, and you can see how excited I am about some of them, that are changing the way, going back to the title of this talk, sort of changing the way of how we define a disease of osteoporosis. And I don't know if Chico remembers a very famous endocrinologist named Gerald Auerbach, who's deceased now, but he's the one who discovered the mechanism of action of parathyroid hormone. But he was asked to give a a state-of-the-art discussion on osteoporosis and its treatment at the Endocrine Society in 1980. And he said there's nothing new under the sun in terms of any real treatment for osteoporosis. That was almost 30 years ago, but not very long ago in the general scheme of things, and certainly predated the development of bisphosphonates. And so I predict, perhaps, that in 20-something or other, somebody, Dr. X, is going to stand up at some august society and say that osteoporosis, maybe I shouldn't have been so bold, preventable disease is clearly treated. And I think, I'm not, you saw my disclosures, being on the periphery of some of the development of these things is just incredibly exciting. I mean, we're seeing a legitimate development of therapies on the basis of what we would call translational research, which is the kind of research that you're doing and you're seeking to find targets for. Go through, I don't want to belabor a lot of this. I mean, you've got a lot of things to do, but I want to focus on a couple of other things at the very least, and I may skip some of these other agents, some of these other areas, but diabetes I don't want to skip. I'm not going to go over the mass of agents that are currently available or are in development to address what I'd have to say are traditional therapeutic targets in the disorder of diabetes. This is a very old slide, but it was reproduced in the 2006 textbook, major textbook of endocrinology, of the targets for current therapeutic modalities in diabetes. Those targets being insulin resistance at the level of skeletal muscle, or at the level of the liver. In terms of the skeletal muscle resistance, you have a defect in ability of insulin to transport glucose into skeletal muscle. And at the level of the liver, you have an inability of insulin to inhibit glucose output from the liver. So you get unrestrained glucose output, and you get difficulty in getting glucose into the mass of glucose disposal tissue, glucose disposing tissue, skeletal muscle. And also you have a relative impairment in beta cell, islet beta cell secretion of insulin. So these are the two defects, defects in insulin secretion, although insulin levels are often very high in type 2 diabetes, largely so that because the pancreas is trying to catch up to the insulin resistance in the periphery. But the defect in insulin secretion is largely related in many people's minds to obesity, where insulin resistance is heightened, and there's a call for more and more insulin. But the islet cells are defective, even though they are hyper-secreting insulin. This is the syndrome that Amrita is studying, and that I think Ben as well is really studying, the metabolic syndrome, of which diabetes is one component. All the readouts of the metabolic syndrome that have been collected and associated in this symptom or syndrome complex of the metabolic syndrome over the past 30 years are listed in these white boxes. Diabetes is one, hypertension, here's non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. Here's a recently discovered polycystic ovary syndrome is another aspect. Certainly dyslipidemia, very common, and atherosclerosis. Certain cancers and pro-inflammatory states are also associated. But the primary etiologic factor appears in all of these to be insulin resistance and hyperinsulinemia, produced in association with obesity, with some genetic components, and also decreased in activity. Here's the real conundrum. What is the inciting effect for insulin resistance and hyperinsulinemia? And that's what I think Ben is studying, the metabolic, some unknown one or multiple, more likely, metabolic dysfunctional events, thought primarily to involve dysfunction of lipid metabolism. And in target tissues. And I think that's what BIN is trying to address. The metabolic syndrome is an age-related phenomenon in men and women. And don't forget that this may be due or associated in part with a change in distribution of body fat and skeletal muscle with age. There's a decrease in skeletal muscle and an increase in adiposity during aging. And that may be why we see an age-related increase in men and women in the prevalence of metabolic syndrome. Well, let me go back to Carcenti for just a moment. And this is where his reductionist creativity is something that I frankly I would aspire to. To me, the most significant potential development in the therapy, in newer therapies for diabetes that I've heard anything about recently come from the bone literature. And the rationale for even looking at this was stated by Carcenti's first author in this Cell paper from 2007. A remarkable feature of most hormonal regulations is that they are controlled by feedback loops, such that a cell type affected by a hormone sends signals influencing the hormone-producing cell. So here he said, well, we've already discovered that leptin, this major metabolic regulator, is sending signals indirectly to bone. Well, there should be some kind of a feedback. There should be bone sending a signal to the energy regulatory system. So he says the regulation of bone remodeling by an adipocyte-derived hormone leptin implies that bone may exert a feedback control of energy metabolism. I mean, it's simple, right? I mean, it's just obvious. Well, they screened osteoblast-specific proteins to see if they could come up with a candidate. And there's one osteoblast-specific protein that we all know about, and we've all scratched our heads about over many years as to what it's really been doing, and that's osteocalcin. And osteocalcin, as you know, is a secreted protein, and I tell you that Longo knows a lot more about this than I. It's a peculiar protein because it has these post-translational modifications on the basis of multiple glutamic acid residues that can be carboxylated. So that it becomes a gamma carboxylated protein at multiple sites, hence its old name, bone-gla protein. It was known as bone-gla protein for many years, and now it's known as osteocalcin. And again, correct me if I'm wrong, but the function of osteocalcin has been guessed at. You'd see a poster here and there in the endocrine society, the ASBMR, but exactly what it does locally or let alone systemically has not been well addressed. Well, it turns out that, to make a long story short, there is another protein that is expressed in bone. It's also expressed in Sertoli cells of the testis, but other than that, it's not expressed too many other places. It's a protein.
Kidney also exists.
Sorry?
Kidney also exists.
The kidney as well? Okay, all right. It's certainly not as specific to bone as is osteocalcin. But it's a protein tyrosine phosphatase. And its activity turns out to regulate osteocalcin's systemic activity to in turn modify multiple energy regulatory mechanisms involved in the metabolic syndrome. It's a complicated up and down arrow type of system, but osteocalcin is the regulator, systemically I believe, that causes a number of corrections of what would be termed metabolic dysfunctions. It increases beta cell proliferation, it increases energy expenditure, it increases insulin sensitivity, it increases fat cell production of adipokines that are insulin sensitizers like adiponectin. It decreases fat mass. All of the things that are wrong in the metabolic syndrome, osteocalcin addresses. But it only addresses it in, as you might believe from the Cell article by Carcenti, in the carboxylated fashion. The carboxylated fashion, which seems to be promoted by this protein, this is the gene ESP that produces this protein tyrosine phosphatase. That protein tyrosine phosphatase in some way, not clear, promotes the carboxylation of osteocalcin and its inactivation. So it's just up and down and up and down. But osteocalcin is the active factor in promoting a correction of the metabolic syndrome. I have to say that in one editorial, in one review article that I've already seen about this, it says, I was sort of glad to see it because this thing knocked me out, and I've been talking to you about it by phone for a long time. It said the importance of these observations to our understanding of metabolism cannot be overestimated. And I just read that over the weekend. I agree. Is there anything else I want to say about that? I don't think so. Let's skip these other things. I don't think it's that relevant to what we want to talk about.
I have a few questions
Yeah.
about metabolic disease.
Maybe some subtle changes in insulin receptors. That's why one of those slides I showed talked about a post-receptor defect. We're still on a post-receptor defect, and I think what that means is that the signaling pathways in the insulin intermediates is reduced in insulin resistance syndromes. And the last point I'm going to make in this talk is very relevant to that. So you've got these serine kinases distally in the insulin signaling pathway that feed back and turn off early insulin signals through the insulin receptor substrate 1 or 2 that are normally tyrosine phosphorylated by the insulin receptor. But once they get serine phosphorylated by these distal intermediates, they can no longer be tyrosine phosphorylated, and so the system is shut off. So that's a normal turnoff. So somehow maybe you've got a hyperactive normal turnoff. We don't really know, I don't think. But it all boils down to probably either mitochondrial or endoplasmic reticulum defects that allow the accumulation of fatty acid metabolites in these target cells that then go and inactivate insulin signaling. That's as best as I can do. Probably the $64 question you're asking. I'm not going to, we'll deal with this some other day. Sorry, Chico. I mentioned your name, and I said my close colleague has made these great strides, and I did mention Humphrey's bear as well. Okay, the last thing I want to talk about, maybe the thing that could tie this together, although in ways that would take us a retreat. Maybe we should have a retreat.
Yeah.
Maybe we should have a retreat to discuss is, and this you probably know as much or more about than I do because of your attendance of some of the bar shop and other talks where therapeutic agents are now being considered as preventable prevention for even aging and death. Are these is aging and is death? Are these things preventable through therapeutic agents? It's real science fiction, right? A lot of this is based on the classic experiments of McKay that were then followed up by Dr. Mazzaro in this institution and others in rodents, showing that calorie restriction, not starvation, but calorie restriction, modest calorie restriction, most cases up to about 40%, decreases the rate of aging and decreases the onset development of age-associated dysfunction and disease. So this is representative of decades of research by Mazzaro and others looking at barrier populations of, in this case, rats, and looking at survival curves with survival on the y-axis as a function of age. In ad libitum fed animals, this is two sets of experiments. The dots represent one set of experiments, and the line represents a different population of animals. You can see how closely they can reproduce these data. But if you food restrict animals by about 40%, you can extend the mean and maybe even more importantly, maximum lifespan by up to 50%. And any number of age-associated physiologic aspects of decline and age-associated diseases, they all follow this same pattern. So, people have wondered, is there such a thing as a drug, a mimetic for calorie restriction, that we could just feed an animal or feed a person that might do this same thing? And I should say that this phenomenon exists in lower forms of life, from yeast to roundworms, C. elegans, and fruit flies, Drosophila, and of course mammals, and even some people believe primates. There's work on monkeys to try to do this, although the monkeys are going to out-survive the investigators in some cases. But there are studies in monkeys, and there even have been some studies in humans over a short period of time. That crazy thing called the Biosphere 2 in southern Arizona, where some investigators went in there and lived for a couple of years and dietary restricted themselves and monitored glucose metabolism and so forth. There were some hints. It was a PNAS paper, actually. Most of them have died by now, and according to Dr. Gregerman, they cheated. You know, they brought in, they were supposed to grow their own foods and have only so much protein and so forth and so on. But anyway, so it stretches along an evolutionary continuum, this phenomenon. So, are there calorie restriction mimetics? That's the question. Most of the work that's been developed to look for calorie restriction mimetics has focused on the insulin signaling pathway, or insulin-like signaling in lower forms, which turn out to reproduce insulin signaling pretty well. So that if you look, there's even another panel we could look at in yeast that follows a similar kind of insulin signaling paradigm that exists in worms, flies, and mammals. I want to focus on a series of transcription factors called forkhead transcription factors, or in flies and mammals they're called foxos, and in worms called DAF16. Life extension in all of these species can be effected by manipulations that decrease insulin signaling. So this is all mutational analysis. So mutations that decrease insulin signaling prolong life. The foxos are transcription factors. They get phosphorylated by prior intermediates in the insulin signaling pathway. And when they get phosphorylated, they get trapped in the cytoplasm, and they don't get into the nucleus to, I will say simplistically, prevent the expression of aging-promoting factors. With a number of manipulations, you inhibit the foxophosphorylation, allow them to get into the nucleus, and they will then promote the expression of longevity genes. There's a series of modulators of these FOXO-like transcription factors called sirtuins, which are protein deacetylases, family of protein deacetylases. The first one, I think, was I think it was maybe discovered in the yeast. It was called SIR2, but the most prominent one that's been described in mammals is called SIRT1. There are 7 of these in mammals. And again, simplistically, what they seem to do is they seem to work in a manner that opposes the action of insulin, opposes insulin signaling. They're deacetylases, so activation of deacetylation, if you will, opposes this insulin signaling, and therefore may be considered a life-extending agent. And it turns out that in multiple species there's evidence, which I will not go into and which I can only begin to dredge out myself, that the sirtuins may be the mediators of calorie restriction in causing life prolongation. So the search is on for sirtuin activators that would be calorie restriction mimetics to prolong life. One thing you're probably questioning, or if you're still awake, and the thing that's really bothered me about this, and people don't, I don't believe people really write about it. Every once in a while you'll have a paragraph about this. Well, for one thing, this is all mutational analysis in animals that are up to mice, it is true, but mostly in much lower life forms of mutational analysis. And how that relates to human aging or age-related disease and insulin signaling in health and disease in humans is not clear. For example, we just talked about insulin resistance, and if you've got decreased insulin action as insulin signaling as a part of the metabolic syndrome in humans, how does that relate to a life-prolonging action of agents that are decreasing insulin signaling? I have no idea. And people, when you go to these talks at the bar shop, you tell me when you find out. I find that very perplexing and very difficult to understand. Nonetheless, and this is a slide that I think could serve as a beginning of a retreat for us, maybe in view of the previous information that I presented to you. Among SIRT activating compounds is this compound which you've read about in multiple sources called resveratrol. And this is the polyphenolic extract from red grapes, and that's in wine. And that that has been invoked in the French paradox. Frenchmen are eating all these high-calorie, high-fat foods, and they're not dying of cardiovascular disease like us, like the Americans are. Are they protected by something? Well, people have said that it's the resveratrol or something like the red wine that's a calorie restriction like mimetic. This resveratrol literature, very controversial. Biochemically, you'd expect that it activated the sirtuins. It activated this protein deacetylase function of the sirtuins. And sure enough, papers have shown that it does that. But it turns out it was probably an artifact of the assay that they were using. So we don't know if for sure whether resveratrol is activating the sirtuins. Nonetheless, it has a whole host of protective effects in addition to prolonging the life of several lower forms of life. The thing that struck me about this slide when I first looked at it, it looked to me, well, it increases insulin secretion. It has protective effects on multiple tissues. It increases energy expenditure. It decreases the development of fat cells. It looked to me like osteocalcin. It looked like osteocalcin. Is it related? I don't know. Might one serve as a mediator for another? I don't know. Well, there's a huge amount of activity in this resveratrol area. This is a paper that raised a huge amount of stir in 2006 in Nature, looking at mice that were fed either, this is survival curve, mice that are fed either a standard diet, a high-calorie diet, or a high-calorie diet in resveratrol. And you can see that the control black line is out to here, and the high-calorie diet, they're killing themselves. You know, and these mice are killing themselves, and that was reversed by the resveratrol. Similar to calorie restriction in these populations anyway, any number of physiologic parameters of physiologic decline, they were also stretched out in a similar way. A subsequent paper came out in 2008.
But they didn't do anything with standard diet plus.
In 2008, they did that study where they tried to see whether this population of animals fed resveratrol would fare. Who knows? I mean, they go out to there. And what they found was, do you know what they found? They found that the number of the, what?
No difference.
They found that a number of parameters, what do you think?
Probably more.
A number of these parameters of health seem to be improved, but the animals didn't live any longer. So we don't know. We don't know. This is a quote in one of the reviews of insulin signaling that I thought was of interest. I mean, lest you think that we are going to prevent decline and aging and death, here's a headline from a satirical magazine from '97. World death rate holding steady at 100%. I don't know if we're going to be able to alter that or not. So what I tried to give, and I think the main issues are these three issues here, are that we're defining, that we will be able to define, that the kind of research that we want to do, or that non-retirees want to do, will change the face of the diseases that we are confronting in an aging population by the development of new treatments, and this just restates that issue. And the thing I wanted to focus on in this slide is that these new therapeutic targets will not only redefine patterns of individual diseases, but maybe even the clustering of multiple diseases. Boy, that's just unbelievable. It's a kind of global creative thinking that we all need to keep in mind. You can't say, this isn't my area of interest. I'm not looking at that. This is not what I'm looking at. It is what you're looking at if another 25 years goes by. And that was the end of the talk that I gave, but Mark put this slide together that is sort of the crux of why I wanted to give this talk here. I believe that the interactions between these two elements are currently under intensive investigation by people who have huge amounts of money and huge laboratories and so forth. I believe that if there's any lesson in all this for us, it's in the intersection of these with aging. And that not many people, for a while, will understand the significance of metabolic diseases as they pertain to changes that occur during aging. And that's where we can maybe develop some mutual interests. All of the things that you're looking at are things that are developing with aging, and that some people believe can be overturned by some of these sirtuin modifying agents. Might we therefore apply an aging context at its simplest, maybe beta receptors in bone, osteocalcin as a mediator of sirtuin action, you name it. I'm not really sure, but it's an opportunity, and I hope we take it. That's my talk.
See, this is the one I was telling you. I had to read again.
Now, Alongo told me yesterday that there's some evidence that only the carboxylated form of osteocalcin is the one that's being secreted. So if that's the case, that's an argument against this line of thinking.
No, I have to read this again.
But that's an issue I didn't talk to you about. It's another aspect of the creativity of somebody like Karsenty. I mean, I think of things going up and go down, but when I think of that, I think of expression of something. So in Karsenty's scenario, the expression, the secretion, I believe, if you will, barring any insights that may come from some of the papers that Luongo is talking about, of osteocalcin don't change. It's the degree of post-translational modification of this protein that is being regulated. It has nothing to do with the expression. Therefore, if one were to look at, okay, you apply aging effect on this, aging effect on that, that's what my whole career has been based on to some extent. But you got to think even a little outside the box in terms of the aging effect on X, Y, or Z, because X may be expression, but Y may be carboxylation of osteocalcin. And Z may be the degree to which osteocalcin is secreted based on whether or not it's carboxyl. So that there may be age-related changes there, which would be huge, huge importance to age-related disease.
See, another thing, osteocalcin is cleaved to different fragments. They are the ones which separate in the blood. And the amount of uncleaved osteocalcin you see is not much, I think. Even the fragments may have...
Well, one can understand how the degree of carboxylation could easily be a regulator of the degree of fragmentation.
See, but the fragments of the osteocalcin which circulate in the bloodstream may have all the effects ESC. See, the reason, anyway, I have to read the papers you were quoting again. The reason why they used unglycosylated one, that's the one easily you can make in bacteria.
Yes.
If you have to carboxylate, you have to use the animal cells. It's not easy.
And they were using co-culture systems. They were using pharmacologic inhibitors, I think, of carboxylation and that sort of thing.
But anyway,
it's somewhat indirect.
Yeah.
Just reminded me. Well, when the editorial, you can just imagine where the search is on now. The editorials speak of the search for the osteocalcin, or I might add, osteocalcin fragment receptor. Where is it?
Actually, I have constructed a vector to express osteocalcin in bacteria. Actually, I may have purified the osteocalcin, but it's a fusion protein. That's what they also did. GST plus osteocalcin, and then what they did, they cleaved GST and the osteocalcin and then purified the uncarboxylated osteocalcin.
Well, you might ask, what would happen if you overexpressed? What would happen if you expressed osteocalcin in the fat cell, where it's not usually expressed? Would there be some kind of adequate? If it has a receptor, would that? I don't know.
No, actually, we have to see the expression. I have a feeling they may be expressed in some osteocalcin because next to is expressed in fat cells.
RUNX2?
Yes.
Protein?
Yes. Yesterday I
Oh, right.
Yeah, yesterday I was
mature
telling you,
fat cells.
Yeah. So we have to check.
It's actually another pathway that I think Randy and Randy Strong probably. I heard that rapamycin
which is
will extend life.
That's right, and that's related somehow to these. I believe that's a target of mTOR, right?
Yeah, yeah.
Which is part of the insulin signaling pathway. And how that's related, I don't know if they've published on that yet. I actually looked before I gave this talk. I haven't seen any publications yet. That's an agent that has been, I think they were giving that as an anti-cancer agent or something.
They are waiting for a patent.
Very toxic.
Yeah, either they are waiting for patent. I think somebody already did the patent based on cell experiment.
Yes, well, let that be a lesson to you. Yeah, I think that has some, it's one of the things I regret not being around here on a regular basis. I'd like to know what's going on there. And
Yeah,
I'm assuming I think they gave a talk about that not too long ago, as I recall. That's how you know about it, maybe.
Yeah.
Yeah, I heard from this informal.
And I think Don Royal was extremely excited about it. I mean, that's at least locally generating lots of excitement. But let's do whatever these agents are. Please answer me the question of how you relate this decrease in insulin signaling extending life to insulin resistance aspects of the metabolic syndrome that certainly don't extend anybody's life. Anyway, you can see I'm excited about this this kind of triad with us being able to maybe deal with the aging aspects. Maybe if you think if everyone can get funded or something, then maybe part of a visit that I can make, maybe we spend the whole 2 or 3 days just sitting around a table or at some place off campus discussing our individual interests or your individual interests, and see if I'll be the facilitator, and see if somehow you can come up with some common goals that will synergize, which I think some of you have been doing already. I think to increase your productivity and competitive submissions. That's all I want. Thanks for paying attention.
It's nice talk. You should give more often than just one or two times.